those on the phone. So today we're here to discuss the military health system's unified response to coronavirus. Our speakers today in the room, we have the Honorable Tom McCaffrey, the Assistant Secretary of Defense for Health Affairs. And then we have Army Lieutenant General Ronald Place, the Director of the Defense Health Agency. On the phone with us, we have the Surgeon Generals from the services, Army Lieutenant General R. Scott Dingle, Air Force Lieutenant General Dorothy Hogg, and Navy Rear Admiral Bruce Gillingham. And then also on the phone, we have Dr. Richard Thomas, the President of the Uniformed Services University. With that, I will turn it over to Mr. McCaffrey for some opening remarks, and then we'll take some questions.
Thank you. Ladies and gentlemen, thank you for joining us today. I'm pleased to have here in the room with me Lieutenant General Ron Place, Director of the Defense Health Agency, and on the phone, the senior leaders of the military health system who are each leading significant efforts supporting the military's COVID-19 response. Lieutenant General Scott Dingle, the Surgeon General of the United States Army, Rear Admiral Bruce Gillingham, the Surgeon General of the U.S. Navy, Lieutenant General Dod Hogg, the Surgeon General of the U.S. Air Force, and Dr. Tom Thomas, the President of the Uniformed Services University of the Health Sciences. We are doing this in part by phone because we felt it important that we engage with you as a team together, but also while maintaining appropriate social distancing. As you know, Secretary Esper has set our priorities, that we protect our service members, their families, and our workforce, while maintaining military readiness and supporting the national COVID response. Military medicine has been at the front lines of the national response, bringing unique and agile expertise and rapidly deployable resources to the fight. Most importantly, we have marshaled medical staffing, getting them to the place where they can do the most good, treating patients. We're mobilizing doctors, nurses, medical technicians, both active duty and the reserve component. As you know, right now, DoD is executing a three-pronged effort in New York City through the high-end capability of the USNS Comfort, our large capacity within the Javits Center, and augmentation of medical professionals directly to 11 civilian local hospitals in the New York area. The Comfort is accepting trauma, emergency, and urgent care patients without regard to their COVID-19 status. The department has also deployed our other hospital ship and expeditionary field hospitals around the country to support hard-hit local healthcare systems. Additionally, roughly 30,000 National Guard service members are offering frontline care to community-based testing, distributing personal protective equipment, medical supplies, food, and water, all part of the concerted national response to serve and support hard-hit communities. For the first time in its 48-year history, the Uniformed Services University has graduated nurses and doctors early so that even as we speak, those new nurses and doctors are on the front lines of the COVID response. The military health system also is heavily involved working to better understand this virus, how to treat and prevent it. We are putting all the best brains in our military medical research facilities working in partnership with other federal agencies on future treatments and vaccines. Our research experts are focusing in on diagnostic testing, utilizing DoD's robust laboratory network to perform testing and pursuing additional types of diagnostic capabilities to include serologic testing to assess the patient's blood for the presence of COVID-19 antibodies. The department has also invested $75 million to research 3 vaccine candidates. We're collaborating closely with other federal research efforts on the promising antiviral therapeutic remdesivir through COVID-19 clinical trials, having previously funded the development of this antiviral for the treatment of Ebola and Marburg viruses. DoD's medical research teams continue to be at the forefront in support of the whole of government response to this pandemic. What the service Surgeons General, Lieutenant Place, and Dr. Thomas will be able to tell you more about today is the wide range of efforts they are involved in, from the surge to buttress our frontline clinical care, to running field hospitals and hospital ships, to lab testing, to aeromedical evacuations, and movement of supplies and equipment to the areas most in need. We're working hard to ensure our beneficiaries have continued access to the care they need, ramping up virtual health capabilities and offerings, establishing drive-up testing sites, and putting the right protection measures in place to minimize exposure risk to both patients and our healthcare workers. We've expanded our nurse advice line capacity to include implementing an over-the-phone screening tool to meet the surge we saw just weeks ago of up to 9,000 patient calls a day requiring medical consultation. Our medical treatment facilities are implementing pharmacy drive-thrus and curbside delivery, in some cases servicing patients in up to 1,200 vehicles a day, demonstrating our ability to protect our people while also staying mission ready. At the same time, we haven't let up supporting combat readiness for service members, even while we've surged laboratory and research facilities to support national and international events. This is an historic challenge for our nation, but the military health system is bringing it all has to bear on this fight, from highly trained medical providers and a world-class healthcare system to cutting-edge research and development expertise and a wide-ranging arsenal of military medical combat capabilities. We are system trained to be agile and adaptable. That's why we're here, and that's what we do. Across the military health system, that's what you see in action today. The men and women serving in military medicine are delivering today on the front lines of hospitals and clinics, in the labs and behind scenes, advancing the priorities of the department to protect our people, maintain our readiness, and support the nation's needs. The impressive MHS leadership team alongside me today, the Defense Health Agency Director, the Service Surgeons General, and the President of USU can describe for you the issues in a very tangible way so you can get a deeper understanding of how we are collectively addressing these complex issues in real time. And with that, we are open to take your questions.
All right, let's go to the phone. Bob Burns from AP.
Yeah, thank you. This is Bob Burns. I think my question is for the Service Surgeon General. Separate from the work you're doing that's connected to supporting civilian agencies and communities, I'm wondering what your planning is. Whether you're planning with the expectation that coronavirus will still be a challenge for the military, requiring extraordinary health protection measures into or beyond the summer.
So let me just quickly before the surgeons jump in, the department has been planning and put out guidance across the military departments, across the department on forced health protection measures that will be in place and be used as the situation adapts, unfolds. Since January, we've put out about 7 or 8 different forced health protection directives that, again, adapt to the evolving situation, aligning with CDC guidelines and everything to do with, personal health measures you take, use of PPE, travel restrictions, guidance to local commanders with regard to, based upon their community and their mission, what they need to take care of their force and keep them healthy and ready. And we would anticipate we will have those in place and evolve those as the situation merits.
But you see, my question was about how far into the summer or beyond the summer you anticipate having to implement these measures and keep these measures in place.
So we work with the CDC in terms of their planning guidance, their projections, and I think what's unique for us, unlike many organizations, we are obviously in all 50 states. We're in over 100 countries around the world, so there's not one way to say how long this is going to in place in terms of our forced health protection measures. It's going to be contingent upon what environment, what mission, and what local community. The guidance we've put out is meant to be flexible based upon the conditions of the mission command and of that local community. And so things may be different in different parts of the country as we go forward.
All right, let's come back to the room.
From the Service Surgeons General.
Hi, Mr. Burns. This is Admiral Gillingham from the Navy. I think we don't have a specific prediction. We're certainly following the models very carefully. But I'll tell you what we've learned, certainly in the Navy, is that with regard to COVID-19, we're learning that stealth in the form of asymptomatic transmission is this adversary's secret power. And so we recognize, despite really our best efforts, we're going to have to learn how to operate with the virus, as General Hyten said yesterday. And so, in coordination with our fleet commanders, we've developed a COVID-19 mitigation framework. The goal is to protect the force and, of course, to preserve our warfighting readiness. The four elements are to identify, and that involves screening, evaluating, and testing as appropriate, isolating those who are positive, containing with numerous measures aboard our ships, to include enhanced cleaning up to 3 times per day, sequestering into small cohorts, mandatory use of cloth facial coverings, meticulous hygiene, and one at a time up and down ladders aboard ship. The other elements, of course, are to appropriately treat as those individuals develop symptoms.
All right. Coming back to the room, Ryan, did you have a question?
I did, yes. Just two quick questions. The first, you mentioned this kind of recent development of surging military medical personnel into hospitals themselves. We understand another tranche has gone today. Can you talk about what is the capacity to keep doing that? I mean, obviously, they've been deploying a lot of your military medical personnel in response to this. New York seems to be the focus. How many more personnel, in theory, could you deploy on that type of mission before you start exhausting your capacity? And what does this say about, you have the Comfort and Javits, which both have about 1,000 military personnel between them. They're basically empty, and not really, the capacity doesn't seem to be much as an issue as much as personnel. Do you plan on deploying more personnel from Javits and from the Comfort into the hospitals, or are you going to leave them there?
So in terms of your first question, the shift in terms of actually utilizing our military medical capabilities around personnel and staffing, you mentioned in New York. So along with managing the Javits Center in the Comfort, and the original purpose of the Comfort was really to be another safety valve for ER and trauma that could arise in the city healthcare system. But what we've found is, while the civilian hospitals are getting to capacity, what they really need is they need that extra manpower, the extra staffing. And so to date, we've already put in close to 400 doctors, nurses, respiratory therapists in New York city hospitals. As you mentioned, we've got another tranche going. So we're now looking and working with CDC in terms of whether those future hotspots, New Orleans, Texas, Detroit, looking at doing the same thing. Where can we really partner with a local hospital that may have capacity, but what they're out of is that manpower. So that's, again, I think a good example of how we're trying to adapt and be flexible based upon the need. With regard to your other question of how is that affecting our own DoD healthcare system, well, we put in a number of measures that we think are helping to reduce the demand on our system that would allow then us to be able to deploy out of our hospitals and clinics to help the domestic response. So, for example, we, like the rest of the country, adhere to the guidance of HHS, and we have delayed elective non-urgent procedures in our facilities for a 60-day period. General Place can add into this, but we have seen that it has had an effect in terms of reduced demand. So we are able to serve our kind of regular patients. We also have seen that our beneficiaries are likely, like other citizens, self-selecting not to unnecessarily go to a healthcare facility if they don't need to. And so right now we're not seeing that we cannot maintain our capacity for our beneficiaries and are able to support these missions. But that's something that we will need to continue to evaluate as we balance what we do for the national response support as well as maintaining our system. But that we'll have to be doing that on a regular basis. I don't know if you have anything to add in terms of
Sure.
MTF.
So much of our function has changed as well. As Honorable McCaffrey mentioned, some folks are choosing to delay some routine care type things, which means that staff is now available to do other things. So as they're deployed out of our facilities, then we're reusing them inside of our facilities for other different things, for example, for our inpatient uses. Further, many of our patients have decided that virtual health is a better way, at least at present, to handle their current healthcare needs. And it takes a different kind of staffing to handle virtual health appointments than it does in-person health appointments. And in general, it takes less people. And so based on the choices that our beneficiaries are making, we're evaluating locally. Local commanders are making decisions about where those people can best be utilized inside those treatment facilities to continue to optimally care for the local population. And because it is taking less, more is available. So the total number more, I don't know what the answer is, but more is available should the department decide that we need to take further action.
Do you have a rough estimate, hundreds, thousands?
Sorry, I don't, sorry.
And then any plans to take all the personnel that are kind of sitting unused at Javits and at Comfort and have them go into the hospitals because that seems to be where the need is?
That would be one of the things we look at both in terms of New York City, but also now kind of pre-positioning any staff we have and being agile enough to say, working with HHS and FEMA, where is the next priority area for the nation, and how do we balance, what we do in New York, other areas, and do we have staff, and also using the National Guard and the reserves to help augment that ability and our ability to kind of allocate resources real time where they're needed.
Just to follow up on that, sir. Did the states get it wrong? This Army Field Hospital in Seattle now had to pack up after not treating one patient for the past 3 days. Mercy and Comfort only treating just a small number of patients right now, despite all this capacity. Javits Center treating a few hundred patients, but there's about 2,000 empty beds right now. Is the problem a shortage of docs and not beds?
Right now, and you see in different communities, it is likely more a shortage of the docs and nurses and the staff you need to run a facility. I wouldn't say that the states got it wrong. I would say that the states were doing good due diligence and planning and anticipating, and rather than being in a situation where they need that capacity and it's not there, I'd much rather have it ready to go, and if we need to reposition it somewhere else, I think that's a far superior position to be in than not have the capacity and there be an extreme need for it.
All right, let's go to the phone lines. Phil from Reuters.
Hey there, thanks very much. You talked a little bit about how the virus's ability to infect people but have them be asymptomatic was its sort of its superpower. I wondered if you could elaborate a little bit on what that means for you exactly. And does that mean, I know that there's been some debate about the extent to which the virus is actually in kind of stealth mode. Do you believe that a quarter of service members may be have been infected, or there's a much? What does this mean as far as your perception of how many service members may be infected, how many of your partner nations' forces may be infected, and then what are you going to do about it? Thanks.
So I believe what Admiral Gillingham was referring to is, based upon what we've seen data here in the United States and elsewhere, is the testing technology we currently have obviously is good for identifying a positive, someone who's COVID-19 positive. And so the value here is you identify that person and you know what to do to treat them, what you need to do to isolate them, prevent further transmission. The issue, the constraint of the current testing technology is you may test negative, but the testing is not so accurate to say that you know that person is negative. So we do know that we have folks who are asymptomatic who may have tested negative who are infected. And so the combination of our current testing, again, is good for identifying those we know are positive, deal with them, and then for those that may have been in contact with someone who has been positive, we do all of the CDC guidelines in terms of what they must do in terms of self-isolation care, that sort of thing. But that's one of the things that the Department of Defense and other entities are looking at in terms of as we get more testing capability and we do more research about what is the prevalence of those asymptomatic positive folks, then how would that inform our own testing strategy as well as nationwide testing strategy?
Let's stay on the phone.
Does that mean the new number we have today is 2,000 forces tested positive, a little over that? Is it fair to assume then that the assumption within your agency is that there are hundreds or maybe thousands more who are positive as well, but not testing positive?
So where I don't want to go is give you a sense that we have a precision that it's hundreds or thousands. What we do know and what we do anticipate or assume is that there are others, not just within DoD, but across the country, who are indeed positive, yet they have not been tested or confirmed as positive.
Okay, let's go to Tara Cott from McClatchy.
Hi, thanks for doing this. I wanted to follow up on the Mercy question and comfort question that Ryan asked. So the Mercy, I think, at current count only has 15 patients. At the not only cost, in taxpayer dollars, but in personnel. Are you all evaluating whether the Mercy should be moved, or if those doctors should be flown into possibly an area with greater needs, such as New Orleans? And at what point does it just become not cost effective to have the Mercy lingering there? Thank you.
Yeah. As you know, the Secretary has designated the NORTHCOM Combatant Command General O'Shaughnessy to be our lead on how we respond to FEMA and HHS requests for support. And he basically is looking at whether it is the Comfort in New York, the Mercy in California, our field hospitals, based upon the data we're receiving, the experience, what's happening in those local communities. He will be making those decisions in terms of the best way to deploy both our physical infrastructure and our staffing. And so I don't want to get out in front and say that we have a decision with what next for the Comfort or the Mercy. That is all going to be reviewed and considered as part of the all-of-nation effort, where the next hotspots are, what are the priorities, and what would be the priorities for our military medical capabilities.
But in hindsight, does it make sense to send the ship, since there are so many limitations were initially about bringing coronavirus patients on board, and maybe instead just sending that medical expertise directly into the communities of need?
So again, when we first responded to requests from FEMA and HHS, there was a concern and a desire that the capabilities of the Comfort, trauma, and ER could very well be needed if indeed the civilian sector in New York was overwhelmed and did not have the capacity to be able to take on those patients. And so it very much made sense that at the epicenter of the nation's pandemic outbreak, that was a very real threat. And I believe that is why the request for the hospital ship, that's why it went up there. That was the original intent. The experience has changed. It could very well be because of the experience in New York City, the directives about staying at home, have less trauma, have less ER, and now we are looking at how would we make better use of that facility. As you know, last week, we made the decision that as necessary, if we need to treat COVID patients in some of our infrastructure, with all the appropriate precautions and protocols, that is something that we will be doing.
Let's come back to the room. Megan?
How many service members have been tested so far for COVID-19? And given we've talked about how many sailors on TR have tested positive and have been asymptomatic, have you given any thought to the plan in terms of widespread testing, especially if there has been a service member in a unit who's tested positive, even if nobody else has symptoms?
I don't have the most current in terms of total number tested. We obviously have the total number of cases for DoD. I'll let Admiral Gillingham speak to the specific Roosevelt situation, but let me back up. One of our approaches as DoD, not just DoD, but across the country on testing is, again, keeping in mind that the current testing technology is good to test you in, meaning you know you're positive, but there's an element of false negatives, so you can't be sure if you test negative that you don't have the virus. And there are right now, there's a finite amount of lab testing capabilities in terms of kits and the reagents and supplies you need. And so in that environment, we want to make sure we devote those finite resources to the highest priority, and that is to indeed test those who are showing symptoms, who we need to immediately treat and immediately isolate. And so that has been our approach. It's consistent with the CDC approach overall. Now, if new testing technology comes online where you're able to do a lot more tests, a lot more volume rapidly, then we probably can rethink our strategy. But based upon supply and demand, priorities, and the efficacy of the current tests, we believe that's a prudent approach.
But knowing that you can't really get the full scope of everything because the testing isn't powerful enough, would it be better to maybe meet it halfway in the middle and just test as many people as you can and hope that that gives you a better number than what you obviously have now?
Not necessarily, because if you were to take that approach either across the DoD or across the country, you may very well be allocating or diverting that finite amount of testing capacity to folks who maybe are perhaps not the highest priority, meaning those that are symptomatic. That's our first priority.
Just a small follow-up to that, sir. Mr. Secretary, why can't you test every sailor before he or she goes to sea?
Again, with the limited capacity in terms of testing, and it's not just the DoD who wants to utilize testing, but the entire civilian sector, and knowing that the current test will show up a considerable amount of false negatives, we don't believe that is the best way to allocate testing resources. And so, again, our focus is on those who are symptomatic and those that we would believe if you focus on that and you can isolate them, that's the most effective way to kind of stop the progress of the virus.
Aren't you worried that when the Nimitz strike group deploys this summer, the same thing's going to happen aboard Nimitz that we just saw happen aboard Theodore Roosevelt?
We obviously are very concerned, and that's why we have issued a series of guidance to the force of all of the things consistent with CDC guidelines that we can do to prevent from occurring. Is testing part of that? Yes, testing can be part of that in terms of the ability to, before a sailor gets on a ship, is there a period of time before that we both do screening, we do the test, and wait a 14-day period? That is something that we are looking at, that could be a good approach going forward.
Social distancing does not.
I'll get to the last question. So we have time for one more question. Let's go to Jeff on the phones. Jeff Schogel.
Thank you very much. DOD has been putting out a lot of information on the coronavirus, and in the spirit of that transparency, I'm wondering if DOD would reconsider its policy of not saying how many service members are infected per installation. Wouldn't that give the American public at large, and specifically the internal audience, a better idea of the scope of the problem and how DOD is rising to meet it? Thank you.
So I will take that it's somewhat out of my lane. We obviously, I would agree, we have been putting out a lot of information about the virus, what we're doing to mitigate its impact on our force and our employees. We do provide daily numbers in terms of total cases broken down by active duty, civilians, contractors. We're going to continue to do that. I know from the operational standpoint and the national security standpoint, there is a discomfort for us to identify, down to a particular base, down to a particular aircraft or or naval vessel, what the cases are, because it does then get into what is the impact on readiness of that particular mission or location, which we don't think is helpful to be sharing in a public way while we recognize we still have adversaries in the world. And so that is the rationale as to why we want to give the information, but we don't want to break it down to particular missions or installations.
Is it really a threat to OPSEC to say, for example, how many Marines and sailors at Camp Pendleton, California have COVID-19? I don't think DoD is saying is that would prompt the Chinese to invade the West Coast. Am I wrong?
Well, I don't know where you would stop in terms of going down that path. You may be able to pick out an installation or a base and not tie it directly to a national security concern, but I don't think it makes a lot of sense. I don't think that it's bringing a lot more value in terms of information if we're sharing with you by demographic, by active duty, by service. I think it's giving you a sense of where we're finding cases and what the disposition of those cases are, so the American public is fully aware of that.
All right, thank you, everybody. That's all the time we have for today. Send me any follow-up questions you might have. Okay, thank you.
Jessica, do you have the number of troops who've been tested? Or does somebody around here, like joint staff or something,
Let me
have
see
it?
if I can find it for you.